I'm Karen Hoffman from MD Anderson Cancer Center, and we did a study investigating whether the diagnosing urologist influenced if men who have favorable prostate cancer received active treatment or if they received observation. So we know that for men with favorable prostate cancer that observation can be an alternative to upfront treatment. It's endorsed by numerous professional societies, and there's mounting data that it's safe, that these men can delay or forego treatment and therefore forego the morbidities of treatment. However, the majority of men with favorable prostate cancer who appear to be eligible for active surveillance nevertheless receive active treatment. And there are studies that have shown that patient factors influence whether or not a patient receives active surveillance, but less is known with regards to the influence of the providers. Accordingly, we use data linked to Cancer Registry, Medicare claims data, both from Texas and the Seer Cancer Registry, to first of all quantify the frequency of observation across urologists, to look for urologist factors that were associated with the use of observation, and then finally to look at the relative contribution of the urologist and patient factors regarding the use of observation rather than definitive therapy. And so what we ultimately found initially, if we just look at the use of observation across all of the urologists, and in our study we actually had 2,613 diagnosed urologists and 17,468 of their patients with favorable prostate cancer. When we looked across all urologists, actually 54% of the urologists had no patients that were managed with observation. If we looked in more kind of the higher volume urologists, those who diagnosed at least 5 patients, were maybe able to draw stronger conclusions, what we found was about 35% of urologists had no patients managed with observation. There also were men on the other end of the spectrum, so 7 to 12% of urologists manage more than 40% of their men with observation. So it seems to be quite varied across urologists, whether men are managed with active surveillance or observation, or whether they get definitive treatment for their prostate cancer. So we looked at different factors that were associated with management with observation, using models that took into account both kind of the urologists and then their individual patients. Similar to prior studies, we found that the older patients, men with more comorbid medical conditions, were more likely to be managed with observation. Though strikingly, 2/3 of men age 80 or older still had definitive treatment for their prostate cancer, though these men tend to have more limited life expectancies. We also found that practice environment impacted whether or not a patient was managed with observation, and really that urologists that worked in office-based practices rather than hospital-based practices were less likely to have patients managed with observation for our study. And when looking at the relative contributions, really what we saw is that the variability in the use of observation was attributed to twice that for urologists than the patient-level factors for our study. So those are the summary of our findings. So really what we found in our group of patients, which were kind of older men with favorable prostate cancer eligible for observation, 85% of them received definitive treatment. And within our study, we found that the urologist was the most influential factor driving whether or not they received observation versus active treatment. And we postulate that this may be because the diagnosing urologist has really the first conversation with the patient with regards to kind of the severity of the cancer and also what the management options are. Additionally, the diagnosing urologist is the one who refers to other clinicians, so it could reflect both the initial conversation and who they refer to for consideration of treatment. We really believe that this is something that's happening at the urologist level, because among those men that were managed with kind of observation or active surveillance, 70% of them saw really only a urologist. So it seems to be at the urologist level, while the other 30% saw both urologist and radiation oncologist. So what our study suggests is that the diagnosing urologist has the potential to influence whether a patient receives observation, active surveillance, or whether they receive definitive treatment. And certainly we think further research is needed to better understand kind of physician characteristics, incentives to try to increase use of observation, and also to make certain that patients are receiving balanced counseling regarding the potential risks and benefits of active surveillance.